if you guys recall, part of cellular respiration, there is actually one of the products is water. Remember 6 molecules of water? So there are other metabolic reactions that produce water. So food and drink mostly and metabolic reaction. That's how we get water here, right? So we do lose a lot of water through the lungs, especially well, when we breathe, obviously, right? If anybody clean their glasses, know that you're losing the water as we breathe. Especially if you breathe through the mouth during the sleep, you can lose a lot of water this way, and of course through the skin. But majority of it is through the urine and small amount in your stool. So this is kind of the water balance, water in, water out. So the most water is lost where? In urine. So that is really the key function. When the kidney regulate the electrolyte, fluid and electrolyte homeostasis, you know, kind of kidney have to make a decision how much fluid and electrolyte to release, to excrete. So they pay attention to the volume, to the osmolarity, the concentration of ion, and to the pH. So whatever we don't need will be excreted, right? And the kidney have a key role in the fluid and electrolyte homeostasis. If you guys recall, right, when we talked about osmolarity, the water always follows salt. And when we're going to be kind of paying attention to how filtration takes place, we're going to really have to follow the salt and the other ions, because knowing that the water will always follow the salt unless there is some kind of an anatomical barrier for the water to follow them. And so, and the concentration of the sodium and potassium is very, very important because we do know they play a role in the muscle contraction, action potential, right? And the nerve conduction, action potential. So the regulation of these ions are very important. And then the calcium, we do know that it's not only important in the neurotransmitter release, coagulation cascade, right? The bone formation and also muscle contraction. So all of this is very tightly regulated, and the kidney play a very important role in the ion regulation here. And of course, the bicarbonate and the hydrogen ion, they play a very important role in maintaining in the pH balance. So all these factors are going to be under kind of very tight control and make sure that we don't get out of the homeostatic range. And the kidney play a very, very important role into that. So let's follow this pathway. If you have a low blood volume and therefore a low blood pressure, we do already know some of the things that the cardiovascular system will do, right? So the volume receptors, carotid, artery, baroreceptors, they will signal cardiovascular system. This is skipping the steps because we already know that. So blood pressure, we do know that the sympathetic nervous system will be activated, right? And the cardiac output will be increased and there will be vasoconstriction. We know that's how the cardiovascular system is going to respond to that. But also, when you have a blood volume, we have the hypothalamus behavior center that's going to increase your thirst for you to seek water. Because if you increase the water, then you increase ECF and ICF, and that will increase blood pressure, right? So it's not only cardiovascular system job to try to return the blood pressure to homeostatic range, but on the kidney side, they will conserve salt, and the water will follow, right? That means more volume will be in the circulation and less excreted. Right? You see what I'm saying? Like a low blood pressure will decrease your urination. And as we mentioned earlier, the high blood pressure will do the opposite. The kidney will excrete salt and the water will follow, and that will decrease ECF and ICF and decrease the pressure. So high blood pressure, many trips to the bathroom. Low blood pressure, less trips to the bathroom. So the kidney in the concert with the other parts of the system, this is the adaptation to the blood volume and the pressure. So now we need to talk about which part of the kidney, specifically the nephron, is responsible for moving water and the solutes. So I think maybe, let's see. I guess we can quickly mention that, but I like to walk you through the graphs better. But, so descending loop of Henle is permeable for water. Ascending loop of Henle, not permeable for water. Once we're gonna start following, we will need to pay attention. But it will actively transport the solutes, especially sodium. And the distal tubules and the collecting ducts, permeable for water, but this variability is, it's variable because it's gonna be under hormonal control. So the descending and ascending loop of Henle, they're not under hormonal control, but the collecting tube and the distal tubules are. And so we need to get all of this together. So hopefully you know these terms. Diuresis is removing the excess of water, diuretic the drugs that do that. Okay, now let's look at this. So here's our cortex, and this is medulla. Take a look at the osmolarity of ECF. The osmolarity of blood, if you guys recall, about the same, 300 milliosmoles. And this is the same in cortex. Osmolarity of medulla is increasing as you go deeper into the medulla. And this is very important. If this was not be a setup, that the whole filtration would not have worked at all. So then how does that work? So even though anatomically the ascending loop of Henle comes first, I want us to talk about descending loop of Henle actually first, because it's a ascending loop of Henle that sets the stage here. It makes it possible for this variability in the medulla osmolarity. So ascending loop of Henle does not permit water to leave the tubule. The water cannot leave. The epithelium is such that the water cannot move. But it is permeable for the ions. So the ions are free to leave, and as they do, they increase osmolarity in medulla. Okay, could you guys remember that? Ascending loop of Henle is not permeable for water, but permeable for solutes. And solutes leave descending loop of Henle and create this increased osmolarity in the medulla. And that's important. That's very, very important. So also pay attention to the coloring of the filtrate. As it comes out of the Bowman capsule, it's about 300, this light yellow, right? So 300. And as it deeps into this, the ascending loop of Henle is only permeable for water and not permeable for solutes. So the water would like to leave, and the reason it would like to leave is because the osmolarity of medulla is high. And the water always goes where there is less water, right? But you see, this osmolarity, high osmolarity, is made possible by this part. So that's why I'm saying that anatomically this follows this, but functionally, it is because we have solutes living here. We create this high osmolarity situation, and the water is actually would like to leave. So as the water leaving descending loop of Henle, when it says reabsorb, you need to understand that from ECF to capillaries. Even though they don't draw the capillaries here, but from ECF to capillaries. As see how the filtrate becoming more and more concentrated? And it goes from 300 all the way to a 1200 milliosmol. So it's kind of equals at this point, because water at this point is not really invited to leave anymore. So it's kind of equals to the medulla osmolarity. And then is the filtrate flowing? Water cannot leave anymore, but solutes leave. And as the solute leave, you can see how the osmolarity is decreasing, because you have less solutes. You following me? We'll start with that again. But we'll say it what we can say it. So, and then in the distal tube, osmolarity is the same as in the cortex, 300. And this portion, the collected ducts, now they are going to be under control of the special hormones that we're gonna probably start discussing on Tuesday. It's going to be regulated depending on what the situation is in the body. Do we need to hold water? Do we need to release water? So we will talk about that a little bit later. But for now, if you guys can notice that this is kind of fixed permeability. Hormonal control is missing here. Water can leave, water cannot leave. Solutes cannot leave, solutes can leave. So those are the two differences between descending and ascending loop of Henle. And then we'll talk about that and the hormonal control on Thursday. Okay, all right. So we'll finish hopefully most of it on Thursday, if not almost all of it. And then on Tuesday, I'll bring questions, okay? So we'll see how much we'll finish.
I have a quick question. So when you were saying, when you were on the ascending, you were saying that the color changes because as solutes or the ions leave. What happened?
So then osmolarity decreases. See, that becomes less.
And that's what has to do with the color?
Yeah, the color becomes less. So see, it comes in diluted, right? Just like blood, because nothing really happened to it. Now the water is leaving, solute stays in because they can't. No transporters here to a solute. So now becoming more and more concentrated. And now as they come up, solutes are leaving, water stays in. So now less concentrated.
You guys are oh my god, you're not gonna make
Okay. Thank you.
Oh my god. And it's
Is descents. So there's a plenty of opportunity for water to leave towards the higher osmolarity medulla, right? There's no problem there as long as the epithelial cells are permeable, right? And so what vasopressin does anybody remember how the vasopressin makes it permeable? What exactly is the change? Kate?
The change is that it
Inserts
inserts the aquaporins.
aquaporins, right? Aquaporins are the channels for water. Water do have a limited ability to go through the cell membrane, but it's really limited because it is polar molecule. So aquaporin is what really makes the water go. So release of the vasopressin will insert a lot of aquaporins here along the collected ducts, and the water is free to go towards high osmolarity and medulla. And once it's in ECF, where is it going to go? Is it going to go to the capillary edge circulation? And so now you increase the volume, right? Increase the water content, and you decrease the osmolarity. Yes? So then, if we actually have low vasopressin, right? Then we do not have an aquaporin, water cannot leave. It's increased diuresis. Look at the urine osmolarity here, 100 milliosmol, so very watery urine, right? As opposed to this one could get as high as the medulla, as high as 1200 milliosmol, very concentrated urine versus very dilute urine. Now, if you think about this scenario, during the nighttime, do you think vasopressin is active or kind of suppressed? Miranda?
Suppressed, I think.
So if it's suppressed, right? So then we over here, right?
Oh,
Would you like to be getting up a lot?
Yes, no.
No.
Best
Over
person
here.
is increased.
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 Yeah.
So you can actually put water bottle circulation, and so you don't have to actually get up that morning. I mean, that much in the night. Get up that much. All right. So here the stimulus, I know you can't see that well, but here the stimulus, and look at one of them here. Osmolarity greater than 290, right? Also, if you look at this one, it says decrease atrial stretch. So how do you think atrial stretch play a role here at vasopressin? Why would that would be a signal for release? Holly? So you have a blow volume, so this stretches, and then?
Because that'll decrease your ability to perfuse the body, so you need more, your body needs to keep more fluid.
So yes, the sensory neurons from the atria will actually go hypothalamus, and by increasing vasopressin, you can put more water in the circulation, right? So that you can increase the blood volume. And of course, the decreased blood pressure going to have a similar effect. Again, the way to just remember about vasopressin, right? It is really what's important is decreases diuresis and increases the blood volume. And so decreased blood pressure, decreased stretch, high osmolarity, all of these three factors need water to go back in circulation, right? Okay. I know you can read this part, but please do spend a little bit of time over this one. And as we talk of producing the hypothalamus and release out of posterior pituitary gland, it's a really nice review of vasopressin. And so, and of course, the antidiuretic is another little kind of reminder. Where are you, vasopressin? Here you are. So once the vasopressin in the circulation, it will bind to the receptor, specific receptor for vasopressin. There's actually multiple variants, we don't really have to worry about that. So vasopressin receptor and the collected duct, endothelial cells of collected duct, this is our cell in blue here. Secondary pathway, again, let's not worry about it too much. The water pouring channels are produced and stored in the vesicle, and the binding of receptor, vasopressin to its receptor, will initiate pathway that will exocytose and put these water pores into the membrane of the, and then that gives an opportunity for water to leave and return to a circulation. Good to see if there's anything else I wanted to. So aquaporin, all right. Okay. So, the other thing that we talked a little bit about, it already started to talk about the loop of Henle, right? Loop of Henle, descending and ascending loop of Henle have very, very different properties, right? What do we already know about descending loop of Henle? What is it permeable for? What is it not permeable? Bayman? Descending, permeable for water, not permeable for solutes. Mm-hmm. And then ascending, Stephen?
It's permeable for solutes and not permeable for water.
Yes, and that's gonna be really important for us here. So the other thing that we will notice is the vasa recta, right, has a very close anatomical relationship with the loop of Henle. And so we will be able to kind of see how this loop of Henle and the vasa recta interact here. So this is a little busy when you look at this figure, but it's not really that complicated. What you really need to pay attention is this. First of all, the flow of the blood in vasa recta is opposite to the flow of the filtrate. And if you just guys are following this slowly, so this is loop of Henle, descending, ascending. this is probably meant to be a water molecules. I'm not sure why they're not labeled as little circles. So what you should be able to see how the osmolarity is increasing, right? It's increasing because water molecules are living. So as it dips in the medulla, remember the medulla osmolarity is increasing, right? So it's inviting the water to come out, and since the loop of Henle is permeable, so why not go towards high osmolarity? And once it's here, it will freely enter capillaries because it's a very permeable, just the one layer of the endothelial cells. So see this, as the water is leaving, right? And as vasa recta bring in the blood, as you can see, the osmolarity of the blood is vary, right? So then there will always be a point, since they go on a different direction, like the filtrate goes this way, and then the blood flows the other way. There's always going to be a point where the osmolarity here is going to be lower than osmolarity here, and the water will go towards the vasa recta. Because you see how, look at this, 1200, 900, 600, 500, right? So 300, 600, 900. So there's always going to be an opportunity to enter higher osmolarity area. And since there is no anatomical reason not to enter, that's what the water is going to do. It's going to leave the descending loop of Henle and enter higher osmolarity layer of level of the vasa recta. And the opposite is happening here, because as the vasa recta comes down, deeps along the loop of Henle, the ascending, as it's shown here, this little bubbles of water, so C blocked, so the water is not leaving. So we have increased high osmolarity at the loop, but then because solutes can leave and actually create that high osmolarity medulla, as they leave in, you see how the osmolarity of filtrates getting less and less osmotic, right? See that? 900, 600, 100, because the solutes are leaving. So then, again, as the solutes are leaving, they definitely have an opportunity to go medulla, but they also have an opportunity to enter lower osmolarity portion of the vasa recta. So this different osmolarity area really kind of driving force for solutes going down the concentration gradient, or for the water move via osmosis down its concentration gradient, because there's always an area of the lymph, one of the lymphs, doesn't matter which one, that is going to be different than the vasa recta. So as long as it's permeable, then it will enter. So I think this speaks to everything that we talked about. So the terms that we often use is countercurrent multiplier. That is really just to say that because the blood and the filtrate move in the opposite direction, that's where the countercurrent word comes from. And it really enables that exchange of water and the solute. Are you guys understanding this, Imani? Okay, so focus on a descending loop of Henle only, right?
Okay.
And pay attention to osmolarity. More and more and more, high and high osmolarity, right? And it's permeable for water. And right near this, the vasa recta bringing the blood with the highest osmolarity. See, as it enters, so let's say this is 600, 700, 800, and right next to it is the 900, right? The water will be invited to come here from the high concentration of water to the low concentration of water. And then on the ascending part, right, the solutes can leave. And again, because the way that the vasa recta enters, it's a low osmolarity, that invites the solutes to enter. Because there is nothing that will prevent solutes entering circulation. There's just no barriers really. It's just very thin layer of endothelial cells. There's no barrier there. And of course, it's permeable for solute. So some of them will remain in medulla, some of them will enter circulation. And the blood flow and the filtrate flow is countercurrent, so the flow in a different direction. So that allows for that exchange of the water and solute. So ascending, not water permeable, we already, what? Yes, ascending, not water permeable. So this slide kind of talks about what we already know, except that it just brings a little bit more information about solute transporters. As always, guys, you really don't need to memorize the name of the transporters, just to appreciate that they are here. And then some of them require energy and for maintaining the homeostasis, because if we move in solutes, then sodium-potassium pump will be working, making sure that concentration of potassium is still lower in the inside and concentration of sodium is higher outside. So with this movement of solute comes many different transporters and symporters and also a lot of energy is used. And this, I kind of want to mention to you, you guys all heard about the Lasix, right? Furosemide, which is sometimes refers the loop diuretics. So the loop here is the loop of Henle. And what they do, they actually bind for the chloride binding site. And so, and they sort of are trying to, prevent making the high osmolarity of a medulla. And so in that respect, the less water is absorbed and more water actually leaves. So therefore the name is diuretics. So, of course it has a place in high blood pressure, heart failures and stuff. So that's where they do work. So a couple other hormones that we have to mention. So first of all, the aldosterone. It controls reabsorption of sodium in the distal tubules and collecting duct. So the distal tubules and the collecting duct. And there are very specific type of cells in the distal tubules. They're called P cells. And the stimulus for secretion of aldosterone is the low blood pressure and the high extracellular potassium concentration. As always, really, really good area to review the aldosterone and its action. Does anybody remember where aldosterone is made? We did mention it once upon a time. Yes, cortex actually, but adrenal cortex, yes. Medulla is just for catecholamines, right? So the aldosterone is still the word just lost, the corticosteroid. So RT. So it's a steroid hormone. And then we'll talk in a minute about their role in the RAS pathway, because we're gonna really discuss this in depth. So with the low blood pressure and high potassium concentration being the stimulus, and really the kind of key effect on this would be is to reduce blood pressure via renin. We'll look at this when we have the RAS pathway and renin. I think it's gonna help you, but just make sure that you kind of note the effect of that. So I know you can't read that. So hopefully you have something to look at, but I didn't know how to make it better. So this is what we need to focus on right now. I can't read it either, so I'm just gonna have to. So we'll start with the low blood pressure. So this is the, this is a, little complicated. Let's see if I could maybe just do it this way, and then we can just go step by step so that at least some of it shows. Okay, let's see. Woo. So when we have low blood pressure, there would be low blood flow rate through the afferent arteriole into glomerulus, yes? Low blood pressure, less blood enters glomerulus, right? Less blood enters glomerulus, the glomerular filtration rate is reduced. Is that clear? Less blood entering, less blood being filtered. Is that clear so far? Okay. So then you have less sodium chloride passing by macula densa. Does anybody remember what macula densa cells are? What are they? They're modified what? Tuesday. They modified
Epithelial
cells of
the proximal convoluted tubule, distal, nope. Collecting duct.
which tubule, is there anything left? Which tubule runs right by glomerulus? Come back. Remember I said that on the picture it was all like opened up so we can kind of follow, but in reality, ascending loop of Henle is actually runs by the afferent and efferent arteriole, right? So macula densa, modified epithelial cell of ascending loop of Henle, and it has a sensitivity to the sodium chloride passing by. So if there is a less sodium chloride passing by, macula densa, I know it says distal tubule, but I didn't write that. I took it from somewhere. It's the ascending loop of Henle. I see now why that's confusing. I didn't even notice that because I don't read that very carefully. It was just, okay, good slide, let's go. Okay, so remember when we talked about tubular feedback, we said that it's going to send paracrine signals local to the granular cells, and the granular cells are modified endothelial cell of afferent arteriole. So it's a macula densa stuck into the granular cells, right? And we do know that besides this paracrine, stimulation, granular cells will also produce something called renin. And I said, well, that we're gonna mention a little bit later because renin will get into circulation. And why renin is important? Because in the liver produces something called angiotensinogen. So when you see something ending like this gen, that suggests that it's a precursor, something before the active protein. So liver always produce angiotensinogen. So it's kind of floating in the plasma, waiting for the renin to be released. The renin is released when the pressure is low. That's a long way to it, but that's what happens, right? The pressure is low, renin is released. And then when the renin is released, it converts plasma angiotensinogen into angiotensin 1. And then we have to go a little bit low in my thingy here. Without renin, there is no conversion. And then there is an additional enzyme called ACE, angiotensin converting enzyme. And you guys probably heard of the ACE inhibitors as a drug. So ACE enzyme will convert angiotensin 1 into angiotensin 2. Now that is the final product that's gonna have a lot of effect. Now the effect of angiotensin 2 will be to what? Decrease or increase blood pressure? Increase it because we're in a low blood pressure situation, right? So this is what the angiotensin 2 is capable of. In addition to all this other activity that we already discussed about, like sympathetic, and all that, it will also vasoconstrict the arteriole by itself. it will send the signals to the cardiovascular center, in addition to what the blood pressure does and all the stretch and in the atria stretch will do. Atria stretch will do. So it will also send the signal to cardiovascular control center to increase the sympathetic response. It will also send the signal to hypothalamus, and that's actually interesting because hypothalamus will increase vasopressin. Because remember, in vasopressin, when we're talking about vasopressin, it was high plasma osmolarity, right? Low stretch, and there was also low blood pressure. So low blood pressure will also increase the vasopressin, and so it will be antidiuretic, so there will be more water in the circulation. That will help to keep the blood pressure high, right? Also, hypothalamus will increase thirst because the thirst and satiety center is located in hypothalamus. Increase in thirst will increase the volume and increase the blood pressure. Angiotensin II is also has receptors in adrenal cortex that will release aldosterone, increase the sodium reabsorption, and the water always follows sodium. So if the sodium is reabsorbed, meaning what's the reabsorption mean? Back into where? From the lumen of the tubules, back in the circulation, and the water will follow. So that also increases the water volume and maintain osmolarity. And this is really this kind of like many different system response to the low blood pressure. And when you heard about, if you heard, did anybody ever heard about ACE inhibitors as a drug for, what do you think? High blood pressure or low blood pressure?
High blood pressure.
It's for high blood pressure.
You can now, what?
For high blood pressure.
High blood pressure, because you inhibited the production of the angiotensin II. And the angiotensin job is what? Increase blood pressure. So if you block this enzyme, there will be no conversion. You block it right here so that you actually will lower the blood pressure. So this is a really, really good figure for you to spend time, you guys. I know it's a lot of component to that, but it's, you know, it's logical. Just have to kind of stay with it for a little bit. So this RAS pathway or renin-angiotensin system, this is kind of goes about all that stuff that we just talked about. ACE inhibitors. Okay. So this particular portion, as you can see, a lot of things is actually kind of relate, and then you see sometimes a very similar responses. But the book does a good job just to kind of point in something that what would be response to the blood pressure? What would be response to the salt digestion in this particular case, right? So if you have a high salt digestion, what it does to osmolarity then? It increases your osmolarity. And if you increase the osmolarity, then, whoops, but there is no changes in the volume, meaning you don't drink more water. So then your osmolarity will increase. High osmolarity, vasopressin release. Vasopressin release, more water reabsorption, kidney conserve water, more water in the circulation, right? But also, hypothalamus has also osmolarity receptors, are very sensitive to osmolarity, and it will also increase thirst. So it's kind of similar to what we just saw before, but many factors can stimulate similar responses. Like the salt ingestion will stimulate the thirst. So increase the ECF, increase plasma, and then make the osmolarity return to normal. Also, if you have a higher osmolarity, usually you have more water intake, and that could increase the blood pressure, right? And actually, this one speaks to salt ingestion, but very high sugar ingestion also retains a lot of water, but not through this pathway, but more through the maintaining osmolarity pathway and through the hypothalamus thirst. And it doesn't stimulate so much of the thirst, but it does increase the water release, decrease the water diuresis, and so you actually could also have a high blood pressure after the high sweet ingestion as well. So for potassium balance, we guys do know that potassium is very important for the muscles and for the heart action potential. So hypokalemia will result in muscle weakness, and then hyperkalemia would actually make the heart beat much faster. It will be get closer to the threshold for the action potential. And so both of these are controlled by the aldosterone. This is a little bit repetitive, but I was gonna try to put them all together. So osmolarity over 280 will stimulate thirst. Simply drinking water will release thirst, will increase the blood pressure. What's interesting is you guys probably experience that, especially if you in the hospital environment, is that when we ask people, like, we don't want to give surgery patients to drink water, right? But giving them an ice, actually the cold water seems to decrease the thirst, specifically cold water. So you could just give patient ice and that decreases the thirst, even though they really didn't change the volume. But there's something about specifically there being a very cold water or the ice that actually will decrease thirst. You can read that on your own. Okay, natriuretic peptides. So, first discovered in brain, and that's called brain natriuretic peptide, BNP, then discovered in ventricles and atria. So now it's the ANP, BNP, and now we even have the CNP. So the key things to remember about the natriuretic peptides, yes, they produced in brain, but they also produced by atria and by ventricles. Let's see if I could. So specifically, they're sensitive to a stretch, you guys. They're very sensitive to a stretch. The key stimulant for the ANP and BNP, and now, as I said, there is another one, is the myocardial stretch, which of course happens a lot during the high blood pressure, right? So increased blood volume causes increased atrial stretch, and that is the key stimulus for the natriuretic peptides to release. They released from the ventricles and the atria, in addition to the brain and a few other organs, but those are the ones that we're gonna. So they stimulate hypothalamus to make less vasopressin. So what's gonna happen if you make less vasopressin? Is your diuresis gonna increase or decrease? Increase. More water leaves the body, right? Which kind of makes sense because the stretch is because the blood pressure is high. So it's kind of opposes the action of vasopressin, right? In the kidney will have decreased sodium reabsorption. Less sodium goes back to circulation, less water goes back to circulation. If more sodium chloride is increased, the water will follow, so it will excrete water. For the afferent arteriole, it will increase the GFR, decrease renin, and of course, decreased renin will activate the RIS pathway and decrease blood pressure as well. Less aldosterone through adrenal cortex and decrease sympathetic output. So all that to lead to decreased blood pressure. So natriuretic, atriuretic peptides, stretch being a key stimulus, and the final destination is to low blood pressure. Okay, so now let's talk about the role of kidney in acid-base balance. We talked before that respiratory system would be the first to respond to the acidosis and alkalosis by hyper or hyperventilation, but kidney has very, very important role after that. So just to remind you, the normal plasma 7.38, 7.42, and we need to regulate the pH for many different reasons. Many chemical reaction, metabolic reaction in our body require enzymes, and the enzymes are protein by their structure, and the proteins are very sensitive to pH. Their functional formulation is this 3D structure that if the pH is wrong, the structure, the 3D structure of the protein could be compromised, and therefore they're not functional. It's like when you, I don't know why this came to mind. Did anybody ever ate those escargot? No, what do you call them? Like you squeeze the lemon. What are those, like escargot?
The snails?
Escargot.
Escargot, is that how you call it? Yeah. So you squeeze the lemon in it, and you basically denaturing the protein in that animal.
Oh, is that why they shrivel?
Yeah, because they've been denatured. So, so the proteins have been non-functional. So a lot of different, like the vinegar and marinades, also based on denaturing the protein. Sometimes you make them more tender, stuff like that. So, but besides this is very important, right? Because the many metabolic reactions are not be able to then be carried out. So it's a pH and the temperature. Those are like two key things that could mess up with the two-dimensional structure of the protein. But also like the acidosis and alkalosis actually have a very important function on the neuron. So we can't really, it's a very tightly regulated, and the kidney do have an important role. So where the acid comes from? Of course, diet and intermediates. Like for example, if you are burning a lot of fat on a low carb diet, then we know the ketone body is by their structures are acids. And then diet meaning like you actually consuming acidic food. Some of course get acidosis. We'll talk about that. Some organic acid produced during metabolic reactions. CO2, as we know, could combine with water and make carbonic acid. So, you know, food and metabolic reactions could lead to production of the acids. We don't have that much of the metabolic sources of the bases. So here it is. So fatty acids, amino acids as a part of the diet, metabolic byproducts like lactic acid as the part of the modified glycolysis, right? The anaerobic glycolysis, CO2 plus water, carbonic acid, ketoacidosis as a part of the fat burning. So all of this will increase the input of hydrogen and decrease the pH, right? So swaying the body in the situation of acidosis. So all that will sway the body in the acidosis. So we obviously have buffers that we know about. We have the bicarbonate, that's a very important extracellular buffer that can bind or release the hydrogen ions. We have hemoglobins, some other proteins, some phosphate in the cells able to also donate or accept hydrogen. And then ventilation, right? Hyperventilation will also control the acidic or acidosis and alkalosis. And finally, the function of the kidney. So what is kidney specifically able to do is either release more hydrogen ions into urine or less. and in that respect, also controlling the acidity of the blood. So let's talk about how the kidneys will do that. So, high plasma concentration of hydrogen, low pH. The chemoreceptors will stimulate the muscle ventilation, right? And we kind of already know a little bit about that. It will increase the rate and depth of the breathing. But in the kidney, we're going to have several transporters that are gonna play a role. On the apical side, which is the one faces lumen, we'll have the sodium hydrogen exchanger. It's called NHE, that's because sodium is also called natrium. On the basolateral, facing the ECF, we're going to also have a symporter for the bicarbonate. Multiple other transporters here. Again, you don't really need to memorize the name of the transporters, but to appreciate the fact that they are, so let me just get right into it, that they are present and what they can do. So for example, one of the examples here, actually this is more like a general, let's just get to a little bit more detail. This is a little bit better, I think. So here's an example of that. So in the proximal tubule, that's one example, we do have an ability for sodium exchange for hydrogen, right? So this particular, the sodium hydrogen exchanger, that's where the name comes from, will bring the hydrogen into filtrate, and it's either could join the bicarbonate and exit that way, and so that will decrease the hydrogen concentration, and it will increase the bicarbonate moving back to circulation. How exactly that happens? So once the hydrogen is entered the filtrate, it will join the bicarbonate, makes carbonic acid, dissociates in the water and CO2. CO2 actually enters back, makes the carbonic acid again, but they don't really show that as an intermediate step, and then it separates again, hydrogen leaves again, but bicarbonate gets to go back to a circulation. So it's kind of very interesting system designed to remove extra hydrogen and put more bicarbonate into the vascular tissue. Another way that could also happen is that glutamine and other amino acids could actually form something called ammonia. And so the ammonium ions hold a lot of hydrogen, and they could be excreted in exchange for sodium as well. And that very typical smell of the urine is usually has to do with the ammonium ion. So multiple way to remove the hydrogen from the body is needed to be. So in acidosis, so this is what basically we talked about, right? But there are multiple transporters, not just only one. In the alkalosis, when we actually have a situation that we need to enrich the blood with the hydrogen, even though this doesn't show going to the blood, but remember I was telling you, if it's an ECF, it'll go here too. So this is actually a slightly different transporter. This one is able to bring the bicarbonate out and then move the hydrogen into circulation. That's in the situation of alkalosis where you actually want to enrich the hydrogen. Multiple transporters, and very, very efficient way to move hydrogen and bicarbonate in the opposite direction depending on the situation. We do have a specialized cell for that in the nephron. So there is like type B, type A. You guys really you really should worry about exactly the naming of it. More to appreciate the fact that the multiple transporters are apical and the basal membrane, and they're able to move the sodium bicarbonate and hydrogen in either direction. All right, so what I was thinking we're going to do next,